I think we can start off the introduction, etc., etc.
Good evening, everybody. I welcome all of you to today's class. We have a very important topic to be discussed today: fever in the neurointensive care unit. And fever is one of the common problems that we face in the neurointensive care unit, and it's one of the unfortunately one of the killers in the patients if we do not take timely interventions. Today's session, it will be moderated by Dr. Ramanan Rajagopal. He is a consultant in Global Hospitals, Chennai, and today's speaker. We are lucky to have with us Dr. Subba Reddy. Over to you, Dr. Raman.
Yeah, welcome on to this evening session. And I take immense pleasure in introducing Dr. Subba Reddy, who is the chairman of the ICCM Hyderabad branch. He's a senior consultant and head of care of Apollo Health City in Hyderabad. And he has very many international and national publications to his accord. And the topic is also very important, as Dr. Zulfikar mentioned properly. It's one of the most important topics in both general critical care and neurocritical care. Especially, it has more weightage in neurocritical care because it has some more understanding for the treating physician to understand and take decisions. Over to you, Dr. Subba Reddy.
Good evening, all. Thank you, Dr. Ramanan, for that nice introduction. Thank you, Dr. Zulfikar. Today, we are going to discuss a very, very important topic, that is fever in neuro-intensive care unit. So we think it is very simple, managing fever in a neuro-intensive care unit. You think it is okay, there are only two causes. One is infectious, the other one is non-infectious causes of fever. And then when it comes to infections, we think it is we think there are limited possibilities in the neuro ICU. We think it may be meningitis, ventriculitis, or it may be wound infection, VAP, COTI, CLBSI. And then we know non-infectious causes, we know very few, like thrombophlebitis, DVT. So, but there is a lot to learn, and then there are a lot of other causes. And then if you miss the diagnosis for a patient who is having fever in a neuro-intensive care unit, if you don't differentiate properly whether it is a non-infectious cause or an infectious cause, and or it is central fever, or it is because of it's because of any drug-induced fever. If you don't differentiate properly, if you don't treat, and then the mortality will be very high. As such, the patients with fever in the neuro-intensive care unit, there's a good evidence to say that I'll start sharing my slides. Sorry. So there's a good evidence to show that there is increase in the mortality when there is fever. They have seen in regular intensive care units, and then they have studied in large number of patients, and then they even published the data. And patients with fever has higher mortality than patients without fever. So in neuro-intensive care unit, again, the fever, because of the fever, the mortality and morbidity will increase. So first, we should understand what is fever, when do you say it is fever, what is the definition for fever, and what are the possibilities for the fever in the neuro ICU, how to monitor fever, what are the methods to monitor fever, and then when there is shivering, how do you manage shivering. So, and is it we know that hypothermia doesn't have any role in the neuro-intensive care unit, but normothermia definitely is required to decrease the morbidity and mortality in the neuro-intensive care unit. So this is my agenda for today's evening. So fever or pyrexia is a physiological response to stress and is a result of an elevation in the hypothalamic set point. So hyperthermia and hyperpyrexia, we know fever and then hyperthermia and hyperpyrexia is different. This refers to a pathological process that is not associated with increase in the hypothalamic set point. So it is usually a diagnosis of exclusion with the temperatures exceeding 41 degrees centigrade. So if it is less than 41 degrees centigrade, then if it is less than 106 degree Fahrenheit, then it may be infectious. But if it is more than 106 degree Fahrenheit and it is hyperpyrexia or hyperthermia, and they don't respond to any of your antipyretic medication, and the causes are always non-infectious. So if you can categorize like this: if the fever is between 101 to 101.8, that is 38.3 degrees to 38.8 degrees, then it may be infectious or it may be non-infectious. Infectious causes we know in ICU we're going to discuss, and non-infectious causes also is a possibility. But if the fever is between 102 to 106, that is 38.9 to 41 degrees, then generally most of the time the cause is infectious. And if it is more than 41 degrees centigrade or more than 106 degree Fahrenheit, then it may be hyperthermia or hyperpyrexia. It is non-infectious cause most of the time. The fever in ICU patient is defined as single temperature more than 101 degrees Fahrenheit or 38.3 degree centigrade as per American College of Critical Care Medicine and Infectious Disease Society of America Joint Task Force, and should be, this is the definition of fever. And then we should start investigating if the temperature is more than 101 or equal to 101 degree Fahrenheit. But in neutropenic patients, if the patient WBC count, the absolute neutrophil count less than 500 cells per mm, and the fever is defined as a single temperature more than 101 degree Fahrenheit, that is 38.3 degrees centigrade, and temperature more than 101 spike of 101 or more than 100.4 degree Fahrenheit or 38 degrees centigrade sustained for more than 1 hour, we call it as fever in a neutropenic patient. But how do you measure this fever? If you want to measure the core temperatures, so then you have to put a PA catheter, and then through PA catheter we have to monitor, or we can use vesicle catheters to monitor, or rectal temperature to monitor the core temperatures. Auxiliary, sorry. So auxiliary temperatures, I don't know what happened. Sorry. So the auxiliary temperature monitoring and all will give you the peripheral temperature monitoring, but not the core temperature. So the fever versus hyperthermia. Fever is always regulated in the hypothalamic thermoregulatory center. A set point rises with the prostaglandin E2, and this is mainly because of the pyrogens like endotoxins, toxins, cytokines, IL-1, tumor necrosis factor, alpha, IL-6. All these cytokines again lead to rise in the prostaglandin E2. So antipyretic like paracetamol block prostaglandin E2 production. So if you look at the hyperthermia, it is not regulated by your hypothalamic set point. The body temperature rises uncontrollably and can be rapidly fatal. The causes are generally drugs like ecstasy, atropine, heat stroke, malignant hypothermia, neuroleptic malignant syndrome, serotonin syndrome. So how do you treat fever versus hyperthermia? Fever, you give antipyretics to block prostaglandin E2 production and decreases the elevated hypothalamic set point. But hyperthermia, you have to identify the underlying cause, and then you have to treat the underlying cause. And antipyretics, they don't have any role in hyperthermia. We have to cool the damp with the damp sponge bath and cool fluids peripherally, but no submersion, because we have to allow the evaporative heat loss. So this is how you treat hyperthermia. Coming to differentials of fever, as I told, the fever is more than 38.3 degrees centigrade. So again, we differentiate fever, pyrexia, and hyperthermia. In the fever, again, we have infectious causes and non-infectious causes. In hyperthermia, we have only non-infectious causes. So coming to the infectious causes, nosocomial pneumonia, and then central line associated bloodstream infection, urosepsis, meningitis, surgical site infection, C. difficile diarrhea, intra-abdominal sepsis, or intrapelvic sepsis. So coming to non-infectious causes, drug fever, any thrombophlebitis. Sometimes drugs also can cause thrombophlebitis if you're giving potassium supplementation, or if you're giving your mannitol or hypertonic saline through a peripheral line, or any DVT, pulmonary embolism, acute myocardial infarction, atelectasis, dehydration, acute pancreatitis, acalyptus cholecystitis, transfusion-associated hepatitis, transfusion-related hemolytic reactions and non-hemolytic reactions can also lead to fever. These are all non-infectious causes of fever. Coming to hyperthermia, we call it hyperthermia when the temperature is more than 41 degrees centigrade, and mainly they are non-infectious causes: acute brain injury, traumatic brain injury, or SAH, or ischemic or hemorrhagic stroke, or thyrotoxicosis, adrenal crisis, and pheochromocytoma, drug reactions like malignant hyperthermia, serotonin syndrome, neuroleptic malignant syndrome. Again, if you can divide non-infectious hyperpyrexia with shock and without shock. If you look at with shock, thyrotoxicosis and then adrenal insufficiency can cause shock. If you look at hyperpyrexia without shock, non-infectious causes and non-hemolytic anemia and all other causes like traumatic brain, like other causes may not cause hypotension, but thyrotoxicosis, adrenal insufficiency can lead to shock also, but drug fever and other causes, transfusion reactions, and then if you are getting fever because of the pancreatitis, and or if you are getting fever because of the acalculous cholecystitis, generally you will not have shock in these patients. Coming to what is the incidence of fever in the intensive care unit. So the fever occurs up to 60% of acute stroke patients, and then you can see 91% of the patients with intracerebral hemorrhage, they get fever in the first 72 hours after hospitalization. The incidence of fever in patients with subarachnoid hemorrhage and closed head injury is as high as is very high, and then it is around 47%. So if you look at the timelines, in first 24 hours, 15% of the patients admitted in the neuro intensive care unit will have fever, but 93% of the patients will have fever when they stay for around 2 weeks. So most of our patients, neuro patients, they stay longer in our intensive care units. So the risk of getting fever is very high, and there is evidence to say that if they have fever, the mortality will increase when compared to patients with no fever. Coming to hyperthermia syndromes in the neuro-intensive care unit, we have serotonin syndrome. This is caused mainly because of the serotonergic drugs, and then it occurs sudden within 24 hours, and it dissolves with treatment within 24 hours. Hyperthermia, more than 41.1 degrees centigrade, tachycardia, hypertension, tachypnea, and then you see mydriasis, the pupillary dilatation, and delirium, agitation, coma. And then other clinical features are there is neuromuscular hyperactivity and tremors, myoclonus, hyperreflexias, diaphoresis, and hyperactive bowel sounds. Coming to the neuroleptic malignant syndrome, dopamine antagonist and dopamine withdrawal. The slower onset, 5 days to week, and mainly we see hyperthermia, tachycardia, hypertension. And again, these patients are agitated, and then they have delirium. And we have neuromuscular hypoactivity, unlike serotonin syndrome. Anticholinergic toxicity, it happens suddenly within 24 hours, and it takes a few hours to days to resolve. And again, the muscle tone is normal here, and the reflexes. Coming to malignant hyperthermia, so we know this is because of the inhalational anesthetics and depolarizing muscle relaxants, very sudden in onset, and it resolves within 24 to 48 hours with treatment. Hyperthermia can be very high, as high as 46 degrees centigrade, and the pupils are normal here. Patients are agitated because of tachycardia, hypertension, tachypnea, and then you get rigor mortis like rigidity, hyporeflexia, hypoactive bowel sounds, and rising end-tidal CO2, and then slowly motile skin and flushing with cyanosis. Very, very high temperatures, you see malignant hypothermia. So it is an emergency. We have to treat immediately with the Dantrol. So coming to, again, hyperthermia syndromes in neuro-intensive care unit. So Parkinsonism hyperpyrexia syndrome, they present with muscle rigidity, like prominent akinesis, and serotonin syndrome, they will have tremor, myoclonus, hypertonicity, and all these patients can have altered mental status, hypothermia, rhabdomyolysis. So the triggers for Parkinsonism hyperpyrexia syndrome are infection, trauma, medication, and trigger for serotonin syndrome, drug combination like MAO inhibitors, SSRIs, tricyclic antidepressants, and opioids. And treatment is escalating dopaminergic treatment in Parkinson-related hyperpyrexia syndrome and serotonin syndrome. We have to stop the causative drug and then basically support to intensive care management. Coming to drug fever, how do you say whether the patient is having a drug fever? It is a diagnosis of exclusion. We excluded all other causes, and then we can say it is a drug fever. It won't start suddenly. You start a drug, it will not. They will not have. They will not develop fever suddenly. They take several days to develop this drug fever, and then they take several days to resolve when you stop this drug. So we don't know the incidence of drug fever in the intensive care unit, but the drug fever incidence must be high in the neuro intensive care units because we use anticonvulsants, and these anticonvulsants can cause fever, drug-induced fever. But even if you stop, the drug fever will not resolve immediately. It takes several days. So the most commonly used anticonvulsants like phenytoin can cause, phenobarbital can cause, carbamazepine can cause because of the hypersensitive reactions. So you should know the mechanism how these drugs are causing drug fever. So some drugs can affect the heat loss like atropine. So and some drugs can increase heat production like thyroxine. If the patient is taking thyroxine supplementation, again the heat production will be very high, and then it can cause like drug fever. And some drugs like pentazocine and these drugs are also can cause, but the most commonly caused blamed drugs for drug fever are phenytoin and carbamazepine and atropine, and to some extent even steroids can cause, corticosteroids can cause. And then sometimes when we give drugs like amphotericin B, they can cause thrombophlebitis, and then even amphotericin B, these drugs can cause fever. And trimethoprim sulfamethoxazole, these drugs also can cause fever, drug-induced fever. And some drugs can cause idiosyncratic reactions and can cause malignant hyperthermia. So all these are the causes for the drug fever. Coming to central fever, a lot of times when you give a ID referral, so when the patient is on very high-end antibiotics, when you start high-end antibiotics, the ID physicians, most of the time they come and they stop the antibiotics saying that this is a central fever and this is not because of the infection. So again, the central fever, how do you diagnose? It is a diagnosis of exclusion. You ruled out all other infectious causes, and then it may be a central fever. So we see central fever in traumatic brain injury. The probable mechanisms here are growth hormone deficiency, direct injury to the hypothalamic pituitary area, or secondary injury from the hypoxia or increased intracranial pressure. And the risk factors, if somebody has diffuse axonal injury and there's a risk of central fever, if somebody has frontal lobe injuries, and young patient with low GCS on presentation, skull fracture, presence of blood in the parenchyma or ventricle, acute brain injury, and location of the skull fracture in proximity to the hypothalamic region, for example, anterior fossa fractures, all these can lead to central fever in a traumatic brain injury. So, and then again, a negative association between early peak fever greater than 39 degrees centigrade and hospital mortality. Whenever there is a central fever in a traumatic brain injury, when the temperatures are more than 39 degrees centigrade, it has got a negative effect on the outcomes. Mortality is increased. The possibility, again, when the traumatic brain injury patient, young patient with traumatic brain injury, we don't know whether it is a central fever or not. We cannot prove. So we use antibiotics, and then because of the overuses of antibiotic, we see emergence of resistance in the ICU. And coming to intracerebral hemorrhage, direct damage to the thermoregulatory centers in the preoptic region, stimulation of the prostaglandin production, and decrease in inhibitory feedback from the lower midbrain, which suppresses the thermogenesis. ICH with intraventricular extension, larger hematoma volumes, basal ganglia and thalamic involvement, third ventricular shift can lead to fever, central fever. And duration of fever was independently associated with poor outcomes. Again, if they have fever, traumatic brain injury, or ICH or SAH, all these patients will have poor outcomes. Coming to SAH, subarachnoid hemorrhage, because of the impaired hypothalamic thermoregulation due to presence of clots in the supracellular system and intense activation of the sympathetic nervous system, and can lead to fever in the SAH patients. Again, a single episode of fever after SAH is associated with poorer outcomes, even in best grade patients. increase in vasospasm associated with central fever. But in regular ICU, if you see, if they have fever, the mortality is increasing. There is a good evidence to say in neuro-intensive care also. But so there is one good trial published in the general intensive care units, that is HEAT trial. So you control the fever by giving acetaminophen 1 gram 6 hourly, and then control fever. And then in one group, they have not used acetaminophen continuously, but there's no difference in 28-day mortality or 90-day mortality. But in neuro patients, definitely the morbidity and mortality will come down, but you need good evidence for you don't require good evidence to say that, and then we can't afford to treat hyperthermias. So these are the causes for the central fever. Again, in all the patients, even acute ischemic stroke, because of the hypothalamic dysfunction, they can have central fever. But again, it depends on the ischemia, like if the ischemia is more, if the infarct is bigger, and then it can cause central fever, and mortality also increases whenever there is fever in acute ischemic stroke. So there's a diagnosis of always is a diagnosis of exclusion. Sorry for that. So it occurs early, typically within 72 hours of admission after acute brain injury and resistant to antipyretic medications. All cultures are negative and just a radiograph should be normal. Fever is disproportionately high and persistent. The temperature peak is higher when the fever starts earlier and will be higher when compared to the infectious fever. As I told, non-infectious causes, the temperature will be very high. The central fever is continuous in nature and it doesn't have any diurnal variations, and then plateau-like without spikes. Relative bradycardia with a notable absence of perspiration we see, and continuous fever lasting longer than 6 hours for 2 or more consecutive days has been considered persistent. The combination of negative cultures, absence of infiltrates in our chest X-ray, and diagnosis of SAH or IVH or tumor, the onset of fever is within 72 hours of admission, predicts central fever with a good probability. So the criteria for SAHs and leukocytosis and all may not be useful to differentiate, but definitely if there is a left shift of immature neutrophils, so then we can say it is infectious. We can rule out central fever if there is left shift of the leukocytes. So coming to the shivering. So when you are trying to control fever, so when you are maintaining therapeutic normothermia, you have to maintain anti-shivering protocol, because again shivering will increase the oxygen consumption. So we have this bedside shivering assessment scale. Bedside shivering assessment scale, if it is less than 1. And so what is bedside shivering scale? So it is 0, no shivering, 1, mild shivering localized to only neck and chest, 2 is shivering involving neck and chest, arms, 3 is intermittent generalized shivering involving all extremities, that is severe. If it is less than 1, so you give paracetamol 1 gram 6 hourly, and we can use counter warming what we have in our ICUs. And step 1 is persistent. If the patient has persistent shivering, then we can use non-sedating agents like maxsulfate, or we can use pethidine or dexmedetomidine or fentanyl at 50 to 200 mics per hour. And if it is a refractory shivering, step 2, we can give propofol 75 to 300 milligrams per hour. And we can paralytics, they don't have any role to control fever, but it can control shivering. So the factors that can enhance increase in shivering after temporary discontinuation of skin counter warming. So moderate to severe shivering at baseline, use of IV infusion, we can use sedation, we can use magnesium, like when the patient has lower magnesium levels, they can have more shivering. So coming to the infectious fever. So in one study, they showed that 50% of the causes, 50% of the time, the fever is because of the infectious in around 387 patients when they studied. And again, in one European study, they showed the similar infection rates. So 50% of the time it may be because of the infectious, and 50% of the time it may be because of the non-infectious. So we discussed non-infectious causes of fever. So then we'll move on to infectious causes of fever. So we know meningitis. So bacterial meningitis, viral, or it may be fungal, parasitic meningitis, amoebic meningitis, or we have non-infectious meningitis. So I will not dwell into meningitis. Recently, we had many classes on meningitis. So fever and meningeal irritation with nuchal rigidity, acute meningitis, either bacterial or viral, with intact mental status and neck stiffness. Encephalopathy, generally there will be mental status or like altered mental status, and they may not have nuchal rigidity. And HSV, mycoplasma, listeria combination, we can have both meningitis and encephalitis. So it can be combination of stiff neck and mental confusion. Mortality and morbidity are significantly high in patients with meningoencephalitis. So they have systemic complications, and then and septic shock in 12% of these patients, and they will have associated pneumonia in 8%. So we know how to diagnose meningitis, analysis of CSF, and then CT is recommended prior to lumbar puncture, but delay in lumbar puncture and perform CT if the signs of impending herniation. You can straight away go ahead with the antibiotics. And then we have clinical biomarkers: CSF lactate more than 3.5, serum procalcitonin more than 0.3, high CRP, and we can nowadays we're using multiplex PCR for presence of bacterial genome in the CSF. So this is how you differentiate the diagnostic approach for the bacterial meningitis, meningoencephalitis, and acute viral encephalitis based on the clinical presentation, based on the usual pathogens. If you look at the community-acquired Streptococcus pneumonia, Neisseria meningitidis, Haemophilus influenzae, and then if you look at the meningoencephalitis, Mycoplasma pneumonia, Listeria monocytogenes, and then the viruses are enterovirus, varicella zoster, herpes simplex virus, and we do lumbar puncture, Ramstein, and then we look at the CSF lactates, and CSF lactates are highly elevated, more than 6 nanomoles per liter in acute bacterial meningitis, and they're between 4 to 6 in meningoencephalitis, and they're not elevated in the viral encephalitis. And we know the empiric therapy, we start with ceftriaxone or meropenem if they have penicillin allergy, and if you suspect listeria, we have to start ampicillin or meropenem. And then if you suspect mycoplasma pneumonia, then we have to start doxycycline. And if it is viral, then we start acyclovir in these patients. Coming to non-infectious mimics, so if they have CNS emboli, subacute bacterial endocarditis, or meningeal carcinomatosis, we see in AML or like acute myeloid leukemia, ALL, lymphomas, melanomas, breast cancer, bronchogenic carcinomas, and CNS vasculitis, SLE cerebritis, sarcoid meningitis, and sometimes drug-induced, like as I told, trimethoprim, sulfamethoxazole. All these things can cause these are the non-infectious mimics. So we need to look at the CSF glucose by blood glucose. It should be less than 0.4, and decreased CSF glucose may be seen in all bacterial, fungal, tuberculous meningitis. And CSF lactate has a huge role in diagnosing post-surgical meningitis fever because of the post-surgical meningitis. It is superior to CSF glucose levels if it is more than 4 millimoles per hour in the neurointensive care units. So if you suspect listeria in elderly people and those with malignancies, and then we suspect mycoplasma pneumonia and meningoencephalitis. If somebody has mycoplasma pneumonia, community-acquired pneumonia, and HSV, aseptic meningitis to encephalitis, depending on the age, we can suspect if it is 5-year kid, then Haemophilus influenzae is common in adults. The regular ones, Streptococcus pneumonia, Neisseria meningitidis, and elderly people, Listeria monocytogenes is possibility more than 60-year-old patients. Coming to nosocomial meningitis, catheter meningitis, the incidence is 2 to 27%, and the most common organisms attributed coagulase negative Staphylococcus aureus, Staph aureus, Acinetobacter, Pseudomonas, Enterobacteriaceae bacteria. And risk factors are repeated catheterization, high catheter, like if the catheter is prolonged, CSF, if you take too many samples from the catheter, and presence of concomitant systemic infection, surgical techniques, post-craniotomy, and post-neurosurgery meningitis, the incidence is 0.02 to 9.5%. And then we see post-traumatic meningitis, and like most of the time it is because of the coagulase negative Staph or Enterobacteriaceae bacteria, and we see in prolonged hospitalized patients. And then when these patients had lumbar or ventricular drains, they are the most common risk factors. So As I told, it may be because the common organisms may be because of cons or staph or gram-negative bacteria, but this is high, the incidence is high whenever there is CSF leak or when the patient is on lumbar or ventricular drains. So how do you treat, what antibiotics we give in nosocomial meningitis? We can give, we have to give vancomycin with cefepime, ceftazidime or meropenem. Again, it is based on your local antibiogram and local epidemiology of your bugs. We have to start antibiotics. Colistin may be given if your incidence of carbapenem resistance enterobacteriaceae or drug-resistant acetobacter is very high in your unit, then you have to use colistin. We have to use intravenous and intraventricular colistin. IV, if beta-lactams are contraindicated, then you can replace beta-lactam with azithromycin, which is available now. Azithromycin and ciprofloxacin, but ciprofloxacin is a bad choice for in our ICUs. And intraventricular or intrathecal antibiotics should be considered if the infection responds poorly to appropriate systemic antibiotics, clinically or microbiologically. So again, based on the CSF analysis, like all of us know how to differentiate between bacterial tuberculosis or viral or fungal or aseptic. So we will look into the salient points. If the glucose is decreased in bacterial and in tuberculosis, maybe normal, mildly less in viral, and fungal it is again maybe normal, aseptic it is low. Lactates are high, as I told, in the bacterial meningitis, and the counts, WBC counts are elevated in bacterial meningitis. Gram-stain definitely positive, acid-fast bacilli positive in tuberculosis. So again, we depend on the we depend on the microbiological cultures, and we depend on the biomarkers like C-reactive protein, and then as I told, CSF lactate can be used, and then and if you don't get the diagnosis, we can use multiplex PCRs. Coming to brain abscess, again, sometimes we miss brain abscess in the neurointensive care unit. It is a focal purulent infection of the brain parenchyma, and like fever is less common than meningitis. When you examine, generally neurological examination is normal. That's why we miss brain abscess in the intensive care unit. Sometimes when you repeat a CT scan, we diagnose, otherwise we miss brain abscess in ICU. And only feature may be raised at ICP, and we see seizures in up to 40% of the cases. They may present with seizure. Suddenly they will have seizure, and then you have to investigate. And depending on the site, they can have aphasia, they can have limb weakness, and then most of the time it is polymicrobial, and there is high recurrence rates if you inappropriately treat, and most of the time it requires surgical intervention plus 6 to 8 weeks of intensive antimicrobial therapy. So the risk factors are immunocompromised patients, and then immunocompromised patients, head trauma patients, recent neurosurgery, and cyanotic heart disease patients. They are at risk of brain abscesses. So organisms are Streptococcus pneumoniae, Staphylococcus and gram-negative bacteria, anaerobes, Pseudomonas, and Haemophilus influenzae. And as I told, 25% of the time it is polymicrobial. The risk factors are otitis media, sinusitis, head trauma, congenital heart disease, or any tooth infections, or hematogenous spread, generally because of the hematogenous spread, or because of the surgery, or because of the immunocompromised state, or if they have associated meningitis, they are at risk of developing brain abscess. Again, we have to use third generation cephalosporins with metronidazole as an empirical treatment, and we have to add vancomycin if MRSA incidence is very high in our unit, and azithromycin if somebody is if somebody is not tolerating beta-lactams, then we can use monobactams like azithromycin, but the duration should be high, and then you should depend on the clinical and radiological response irrespective of your irrespective of your excision abscess. So we have to do source control, and then you have to use antibiotic therapy for longer durations. Coming to subdural empyema, infection of the potential space between the dura mater and arachnoid, and clinical features are altered sensorium, focal neurological deficit, seizures. So we know the subdural space is less restrictive as compared to epidural space. So there's a wide spread of empyema. And then it can cause encephalitis, brain edema, mass effect, increased ICP, and then it can cause cerebral venous thrombosis, and we see more complications and worse outcomes as compared to epidural abscess. So the common organisms, again, streptococci, staphylococci, and anaerobe. So we need to cover, we need to give good anaerobic coverage when you are having empyema, subdural empyema. The empirical therapy, third generation cephalosporin or meropenem with vancomycin plus metronidazole, 6 weeks IV and 4 to 6 weeks oral we need to give till complete resolution. So coming to ventriculitis, the complications like we see like ventriculitis post procedure or primary ventriculitis is very, very rare. And then these patients will have hydrocephalus and raised ICP features, altered sensorium with seizures. So 2017 IDSA clinical practice guidelines, they released it for healthcare associated ventriculitis and meningitis. When they have EVD, the risk is very high. And the most common organism, staph epidermidis aureus, and 25% of the time it is gram negative, E. coli, Klebsiella, Pseudomonas, Acinetobacter, and usually from the peritoneal end. But in our intensive care unit, it's not more than it is always definitely much higher gram negative ventriculitis we see than the gram positive like staph epidermidis or aureus. And the initial antibiotic regime according to IDSA guidelines, vancomycin plus cephalosporin. But in our units, intravenous polymyxin E, that is colistin. So because the incidence of Acinetobacter, Pseudomonas, Klebsiella is very high, so we have to use intravenous colistin, and then we have to use intraventricular colistin around 1 lakh units every day. We need to give intraventricular colistin. And then if staph or enterococci are suspected, then you can give intraventricular vancomycin. Coming to shunt infections, which we see in the neuro-intensive care unit, if they have new onset headache, nausea, lethargic, change in mental status, or fever in absence of other clear source of infection, and if they have signs of peritonitis or abdominal tenderness when they're having BP shunt. So when you don't have, in absence of other clear etiology, we suspect CSF like shunt infections. And so what is the best approach to prevent infection when they're having CSF shunts? So peri-procedural prophylactic antimicrobial administration is recommended for patients undergoing CSF shunt or drain incision. Prolonged antimicrobial prophylaxis for the duration of the external ventricular drain is not recommended, because if you give prolonged antibiotics for the patient who is having shunt, they may develop shunt infection with a multi-drug resistant bacteria. Antimicrobial impregnated CSF shunts and CSF drains are recommended. So MRSA, staph epidermidis, Pseudomonas in Western world, but MRSA incidence is low in our country. So the recommended empirical therapy will be ceftazidime or cefepime plus or minus vancomycin, rifampicin for gram-positive shunt infection that failed to clear vancomycin. But don't use rifampicin. More commonly, don't use without evidence, because rifampicin again we use for TB treatment in our country. Otherwise, the TB bacteria will develop resistance if we use rifampicin without much evidence. So gentamicin can be used intrathecally, and we can use intrathecal colistin. We can use intrathecal vancomycin in these patients when they're not responding to regular antibiotics, if the drug resistance is very high in our ICU. The CNS infections caused by MRSA, so then we have to treat with IV vancomycin plus or minus rifampicin 600 milligrams daily for 4 to 6 weeks. And alternatively, we can use linezolid 600 milligrams IV twice daily, or we can use trimethoprim sulfamethoxazole 5 milligrams per kg per dose IV every 8 to 12 hours. For brain abscesses and subdural empyema, spinal epidural abscess, we have to give 4 to 6 weeks. And for meningitis, 2 weeks are enough. But when you are giving, you have to look for clinical and radiological clearance to stop the antibiotics. So other than neuro infections, we can see like patients can develop ventilator-associated pneumonia. So the most common organisms in our intensive care unit are gram-negative multi-drug resistant bacteria, Acinetobacter, Klebsiella, Pseudomonas. Staph is rare. And the risk factors we all know: when the age is more than 60 years, duration of mechanical ventilation, prior antibiotic usage, and ARDS preceding VAP, and renal replacement therapy when the patients are on systemic and corticosteroids. And we can use non-invasive sampling most of the time. ball is not required. With a good endotracheal aspiration, we can get a sample, and then we can get the culture positivity. And the initial treatment will depend on your antibiogram and local epidemiology of your bugs, and to reduce the development of we have, and all the ICU should have proper antibiogram to reduce the development of resistant infections, minimize the antibiotic usage, and specifically we should avoid MRSA coverage, because our incidence of MRSA in our intensive care units is very, very low. And we have to use short course of antibiotics, and then we have to we should have a proper de-escalation policy in our ICUs. And monotherapy versus combination therapy, it depends on the type of bug. And commonly used antibiotics for treating VAP, piperacillin, tazobactam, and then we have carbapenems, we have polymyxins, and carbapenem resistance is increasing. And the single, and like the patients with VAP who are not at high risk of MDRs in ICUs with low prevalence of MRSA, the resistant, and we see more gram-negative organisms in those ICUs. The incidence of MRSA is less in those ICUs, but in Western world, gram-positives are more common. In our ICUs, gram-negatives. So we have to use broad spectrum antibiotics when the patient is having VAP. So how many days you need to give antibiotics? We have to give a short course, 7 to 8 days of antibiotic therapy, and longer duration. And if the VAP is not responding, or if they have severe immunodeficiency or bronchiectasis, empyema, lung abscess, necrotizing pneumonia, inappropriate initial antimicrobial therapy, in all these conditions, you have to give longer duration for 14 days. So when do you start anaerobic coverage? Generally, like people give atypical coverage, people will give MDR bugs we cover, and then when to cover anaerobics, and when to give when to cover anaerobics. So anaerobic bacteria can cause VAP in 2 to 7% of the patients. Risk factors are when you suspect aspiration pneumonitis, if the patient is in altered sensorium, and if the patient aspirates, then we have to use either clindamycin or metronidazole, but clindamycin is a better choice when you're suspecting anaerobic bacteria. And when do you cover atypical coverage, like when do you give levofloxacin, moxifloxacin, azithromycin, or clarithromycin? The atypical bacteria causing VAP is very less, it is 5 to 7%. Whenever there is a risk factors for VAP due to Legionella, because when our hospital water supply is colonized with Legionella, or prolonged use of corticosteroids, or if the patient is having on cytotoxic chemotherapy, elderly people, chronic renal failure people, then we need to cover with atypical antimicrobials like fluoroquinolones and macrolides. So coming to catheter-related resting infection, the incidence is 2.4 to 12%. So in our ICUs, it is around 2 to 3% in our ICUs. And so the risk factors are longer indwelling catheter duration, immunosuppression, diabetes, and the most common organisms are cons, Staphylococcus aureus, Enterococcus, and Candida. Candida is again the incidence is increasing, but again the gram-negative organisms causing catheter-related infections are also increasing in our intensive care units. So we need good 2 to 3 sets of blood cultures for diagnosis of all these infectious causes in the neuro-intensive care unit. You should know how to take proper blood culture. 20 to 30 ml of blood, blood you have to take, and then you have to clean the surface with chlorhexidine around, and then you have to wait for 1 to 2 minutes before you take the cultures. So you have to take good amount of proper amount of blood, and then you have to properly collect it. Otherwise, you will not get proper you will not diagnose. And if you don't start antibiotics early, then the mortality will increase. So we use vancomycin plus or minus cefepime depending on your antibiogram in the intensive care units for treating CLBSI. Coming to catheter-associated urinary tract infection, the incidence is very high in the neuro-intensive care units because we use like all our infection control committee meetings. They say neuro-intensive care units, number of catheter days are high, number of COTIs are high. So always they warn us So decrease the usage of catheters in the neuro-intensive care unit. I don't know how feasible like it is, because if you remove without proper assessment, if the residual urine is very high, if you don't monitor your residual urine after removing your catheter, then again that may lead to increase in incidence of cystitis, pyelonephritis and all. So the incidence in neuro-intensive care, COTI incidence is very high. The most common bacteria causing COTI are E. coli, Klebsiella and fungi like Candida. And the risk factors are duration of catheterization, length of ICU stay, prior antibiotic usage, higher disease severity scores, female gender, and the prevalence of ESBLs, multi-drug resistant bacteria causing UTI, is very, very high. And we need to start, what are the antibiotics we have? Aminoglycosides, but they develop resistance very fast. And then carbapenems, and 70% of the time your carbapenems resistant bugs will cause COTI. And fosfomycin is a good antibiotic if you're suspecting E. coli or Klebsiella. And Candida, if you're suspecting, generally, if you find Candida, like it is, you should not routinely start antifungal unless it is unless they do some instrumentation, or it is real. If it is causing UTI, then if the patient is having fever and risk factors, then we have to start antifungals like fluconazole. So most of the time, neuro infections are caused by cons, and then we have to use oxacillin 2 grams IV 4th hourly. But there is no point using vancomycin when you get coagulase negative staph, and then we have to use like if you're trying to keep the catheter, then we can give antibiotic like oxacillin for 10 to 14 days to salvage the catheter. So we have to differentiate between MSSA and MRSA. MSSA, we have to give oxacillin 2 grams IV 4th hourly. If it is MRSA, we have to go for vancomycin. And if the patient has penicillin allergy, we can give vancomycin, or we can use daptomycin in MRSA 10 milligrams per kg once a day. So if you suspect catheter infections, remove catheter, and then vanc is inferior to oxacillin when you have MSSA in the cultures. So we should not use vanc. So as I told, Candida, so when you get yeast in the blood, it is not a contaminant. Last time also we discussed, if the blood cultures are growing Candida, it is not contamination, and then you have to start fluconazole if the patient is stable. If the patient is unstable, then we have to start echinocandins like micafungin or anidulafungin. If it is Candida krusei, fluconazole should not be used, because there is an intrinsic resistance, and then we can use echinocandins in these patients, and then we have to do ophthalmic examination to rule out Candida endophthalmitis, and then we have to do transesophageal echocardiography to rule out any endocarditis. So coming to the last but not least, this is also very important, Clostridium difficile infection. So we see the incidence of C. difficile infections in the neuro-intensive care units are increasing, and so before you send the sample for C. difficile, we should stop the laxatives for 24 to 48 hours before you send the stool for sample. So when you get positive report, so if the patient is asymptomatic, and then if the patient is asymptomatic carrier, then you may not treat. But if the patient has mild to moderate disease, you have to give metronidazole 500 milligrams 8th hourly oral, or nasogastric tube. If it is severe, then you have to give vancomycin 125 milligrams 6th hourly. If it is complicated, then we have to immediately give colorectal consult, and then we have to use vancomycin at higher doses like 500 milligrams 6th hourly plus metronidazole 500 milligrams 8th hourly. So you should know know the indications for vancomycin when the patient is not responding to metronidazole, and sometimes you have to combine both metronidazole and vancomycin if it is severe C. difficile diarrhea. These are the recommendation: metronidazole first line of treatment, and then oral vancomycin we can use, and if it is severe C. difficile diarrhea. So the dosage is 125 milligrams 4 times daily, then 125 milligrams first 10 days we have to give 4 times, then 7 days you have to give twice, then once daily. And then we have to clean the hands with soap and water. Now you cannot use the regular AHDs as an infection control. We have to take contact precautions. We have to prevent the spread of C. difficile infection in the neuro-intensive care unit. Thank you so much, and I'll be happy to take some questions.
Anybody having any questions? Yeah, welcome to. It was a comprehensive and superb presentation of a very vast topic. Though the topic is simple, the coverage is very, very wide. For PGs, I would like to tell 1 or 2 points extra. One is, in any neuro ICU, whenever there is a drop in GCS, that's the first indication that there is some infection or fever, which they have to remember. And yeah, we have some special subsets of patients, like immunosuppressed patients of neurology, neurotrauma, subarachnoid hemorrhage, all of them presenting with fever. And if they have fever, the management is, don't assume central fever first, as you rightly pointed out. Treat it as an infectious fever, and then once it is rolled out, then we can de-escalate the antibiotic and stop. And serum procalcitonin is a very wonderful guide in all these settings, as you also rightly told. That's a very important point.
Yes, definitely. And the diagnosis is very, very important.
Exactly.
And like recently, we had one patient in our intensive care unit, and this patient was having fever, and then this patient was having vomitings, but no abdominal tenderness, and LFTs were normal, amylase lipase were normal. There was no abdominal pain. When we did ultrasound, we diagnosed acalculous cholecystitis, and there was a huge collection. The patient was not stable for cholecystectomy. Then we kept a pigtail catheter, and then after keeping the pigtail catheter, and the patient, the vomiting subsided, diarrhea subsided, and the fever has come down. Patient became stable. So, and then we are waiting for interval cholecystectomy on this patient. But the diagnosis is very, very important. It may be non-infectious or infectious, as you rightly said. We have to rule out or like first infectious cause in the neurointensive care unit, because these are treatable causes. Then you can go for then we can always, your non-infectious fever is always a diagnosis of exclusion.
Yeah, and though we say rare things should not be remembered, I think the point which you put out correctly, in stroke, especially in diagnosis of infective etiologies of stroke, we should always remember to do a esophageal echocardiography to rule out infective endocarditis, which could be a potential source for embolic strokes. So that's one thing which we have to remember.
And then when the cultures are growing candida, you must do ophthalmic examination to rule out your candida endophthalmitis, and then you have to do transesophageal echocardiography to rule out any endocarditis. And you must know what antibiotics to use. It depends on your bacteria, and then it depends on the site of infection. So if you are treating VAP, then the polymyxins have limited penetration into the lung tissue. So you should know the antibiotics which has good penetration. So if you are treating candida infection, if somebody has candida pyelonephritis, then the penetration of like azoles or the penetration of echinocandins are very poor. So sometimes you have to see which echinocandin has got a good penetration into the renal parenchyma. So that's why in my presentation I showed micafungin, because there are good case reports and good evidence, some like case series to say that micafungin penetration into the renal parenchyma is better than anidula or caspofungin. So slightly better than anidula and caspo. So you should know type of antifungals or antibiotics to use for different infections in the ICU. So you sometimes it is very difficult for us to treat. Like we have the new antibiotic like ceftazidime avibactam with azithromycin. So when to use colistin or when to use ceftazidime avibactam with azithromycin. So if you are treating pneumonia, then ceftazidime avibactam with azithromycin is a better antibiotic than colistin because of the better lung parenchymal penetration. So sometimes when you are not able to diagnose, when you are not able to treat, then there's nothing wrong in taking opinion from the physician or ID physician in your hospital, but we should not miss the diagnosis.
Yeah, true. So, Dr. Sulfikar, if there are no questions,
So any comments from Zulfikar sir side? Sir, any comments from your side?
Yeah, thank you, sir, for an exhaustive review. There are no questions. I have a simple clarification. So what do you do in your clinical practice once we have to resort to one of the common measures that we resort once a patient is febrile is to cool the patient. So do you go for a surface cooling or do you resort to core body temperature cooling? What is your clinical practice?
So we generally use surface cooling methods. We use surface cooling methods only.
yeah, I think they act faster also.
Yeah.
Yeah. I don't feel there is any question from our students. Most of them are silent.
And it is a very, very, I think it's a very easy topic for them, fever in IC. Have any questions?
There's
So
one more
There is
question.
one.
Are there any specific risk factors in neuro patients?
Yes, definitely. So if the neuro patient has the catheter for long time, if the patient is having a PICC line for longer time, so or if the patient is having, and then we use generally the Candida colonization index, and then when the patient is growing Candida from multiple sites, so then the risk of Candida infections are very high. So and then if the patient is not if the patient is on multi-drug, if the patient is having MDR infections, and if the patient is on broad spectrum antibiotics for more than a week or 10 days, and then they are prone to develop fungal infections. And again, the immunocompromised patients, and the patients are on TPN, or patients associated with again any GI complications, or a head injury patient with again abdominal trauma, so with peritonitis. So we generally suspect Candida infection, and then we start empirically. Initially, we start antifungals, and then we wait for the cultures, or we can use biomarkers like 1,3-D beta glucan or serum galactomannan to diagnose fungal infections. So these are the risk factors generally for Candida in the ICU. There is one more question, I guess, that is from Sharath. How do we recognize a fever due to hypothalamic cause? Yes, again, you should know the diagnosis of your patient and what, like as I told, traumatic brain injury, and where is the skull fracture, or where is the, how is your scan, or is it a massive ischemia, or intracerebral bleeds, or subarachnoid hemorrhage. And all these patients, we can suspect hypothalamic cause for that fever, that is central fever that we extensively discussed in my presentation. But again, to say it is hypothalamic cause, you rule out other causes. And as I told, it's a diagnosis of exclusion. And then we can say it is hypothalamic cause for the fever.
Dr. Subba, I don't feel there are any more questions.
Yes, sir.
Yeah, I think we can end this session as there are no queries. Dr. Ramanan, shall we?
Sure, sir.
Thank you, everybody. We'll just end today's class, and we'll just meet again next Thursday.
Sure.
Thank
Thank
you.
you, Zach, and thank you all the participants.
Thank you, sir.